Hello everyone. So today's video is all about the pharmacology of the prokinetic drug in relation to the G2 receptor antagonist, which includes metoclopramide, domperidone and levosulpride. Metoclopramide enjoyed the most widely used antiemetic drug and it is very commonly asked as a short note in the exam. I'm Dr. Meenakshi Gupta from the Conceptual Pharmacology channel. Now let's get started with the topic prokinetic drug. Now what do you mean by a prokinetic drug? As the word itself says, prokinetic, whenever the kinetic word it comes, that means we are talking about the movement of the something. And here we are talking about the movement of what? We are talking about the movement of the gut. What kind of the movement happens in the gut? It is a peristaltic movement. And what is a peristaltic movement? It is a series of wave-like contraction. It is a series of wave-like contraction which happens in the gut wall. So what happens exactly? There is a contraction of the proximal segment of the gut followed by a dilatation of the distal segment of the gut. You can see here, this is the normal gut with the food particle, normal lumen you can see. Now what happened with the peristaltic reflux? There will be contraction of this proximal segment. So this portion it is contracted followed by a dilatation of the distal segment, and here it is a food particle. Why it is required? Because with the contraction it is going to push the food in the forward direction and this portion it is ready to receive the food. Now this is the normal. How this thing happen we will discuss in the physiology of the gut motility. But sometime what happens if there is any problem? Suppose there is a decrease in the lower esophageal sphincter tone, then what will happen? Instead of moving forward, the food will regurgitate back into the esophagus. That leads to the heartburn. And if there is any post-operative paralytic ileus, and there also food will not move forward. Any short-term gastroparesis. So these are the condition where the food does not move in a forward direction. That is the time when we have to prescribe to the patient this prokinetic drug. So what are the prokinetic drug? These are the agent which is going to cause the peristaltic reflux, so that which is going to further enhance the gastric emptying. मतलब जो खाना स्टमक में है वो आगे मूव करेगा तो गैस्ट्रिक जो है there will be emptying and further leads to evacuation of the bowel. And all this happens in a very coordinated way. Now let's see what is a prokinetic drug. So prokinetic drug, they are the agent which increases the peristaltic movement of the intestine so that the gastric emptying happens and even evacuation of the bowel may be achieved. So prokinetic agent, it all does, it stimulates the GIT motility, it increases the lower esophageal sphincter tone. So we can use this one in the gastroesophageal reflux disease, or we can see GERD. Speed up the gastric emptying. So for the short-term relief of the gastroparesis, there we can use stimulate the small intestine. So we can use it for the post-operative paralytic ileus and enhance the colonic transit. So we can use this one even for the constipation. Now coming to the second one, physiology of how this happens, physiology of the gut motility. So in the GIT, there is one system, that is enteric nervous system. Now this system, it consists of what? It consists of two type of plexus. One is mucosal or submucosal plexus and mesenteric plexus. So submucosal plexus, this is present beneath the, I'll write correctly. So it is a submucosal plexus. It is present beneath the mucosa and its main action is secretion. Whereas mesenteric plexus, that is present in between the circular and longitudinal smooth muscle and its main action is a motor activity, or you can say this is the one which is responsible for the peristaltic reflex. Now the main neurotransmitter in this mesenteric neuron is acetylcholine. So this is a cholinergic mesenteric neuron. This is going to receive the input from further excitatory and inhibitory. Excitatory neurons and inhibitory neuron. Now how these neurons they are stimulated? Let's see the next picture. This is the mesenteric neuron. Cholinergic mesenteric neuron, because main neurotransmitter here it is acetylcholine. Now this is receiving the input from the further two interneuron. You can see here one is excitatory and another one is a inhibitory. Now how these two interneuron they get stimulated? They get stimulated with the mucosal stimulation of the gut. This is a mucosal lining. So whenever the person eats food, what happens? That causes the distension of the gut wall. And that distension of the gut wall, this is going to cause the stimulation of the mucosa. So here it is a broader picture of the mucosa you can see. And mucosa, there are various type of cells. And one of the important cell, that is EC cell, that is enterochromaffin cells, which contains 5-HT, that is serotonin. So remember one thing, more than 90 to 95% of the serotonin of the body that lies in the gut, and especially in the anterior nervous system, and which causes the peristaltic reflux. Now this 5-HT, once it is released, it is going to act on the receptor, 5-HT3 receptor, and it is going to cause a stimulation of the two neuron. One is intrinsic and other one is this is intrinsic, and the another one is extrinsic, which is not shown in this picture. Now what does intrinsic primary afferent neuron, what does it is going to do? This is further going to cause the stimulation of these excitatory, right? This excitatory and inhibitory neuron. With the help of what? Excitatory, there are 5-HT4 receptor, and inhibitory, there is involvement of 5-HT3 receptor. And with the excitatory, there is a release of acetylcholine. And release of acetylcholine, this is going to cause the contraction. Whereas with the inhibitory neuron, there is a release of NANC, that is noradrenergic norcholinergic neurotransmitter, that is NO, nitric oxide, and this is going to cause a relaxation. So the two interneurons, excitatory, inhibitory, acting through two different type of receptor. Excitatory, that is acting through 5-HT4, right, and inhibitory acting through 5-HT3, and one is going to cause a release of acetylcholine and another one is going to cause the release of nitric oxide. This is going to cause the contraction and this is going to cause the relaxation. So this is how the peristaltic reflex happens in the GIT. Now there is another neuron which is making a synapse with this cholinergic myenteric neuron, that is a dopaminergic neuron. So this is a dopaminergic neuron, and this is going to cause the release of dopamine, and that dopamine, how it is going to act? It is going to act through D2 receptor. This, which is present on this neuron, and once this gets stimulated, it is going to inhibit, say, this dopaminergic neuron. It is going to act through D2 receptor, and this is going to decrease the release of acetylcholine. So it has got the inhibitory influence. Remember one thing, this dopamine, it has got the inhibitory influence on the cholinergic myenteric motor neuron. So this was all about the intrinsic primary afferent neuron. Now what this extrinsic primary afferent neuron it does? This will be carried by the vagus nerve and the dorsal root ganglion to where? To the vomiting center. Here, to the vomiting center. It is going to carry the impulse to the vomiting center via nucleus tractus solitarius, and it is going to induce the vomiting. So this 5-HT3 antagonist, like ondansetron like drug, they are going to act partly as an antiemetic by blocking this peripheral pathway. Otherwise, they are going to act directly on the CTZ center, where by blocking this 5-HT3 receptor, on the vomiting center, again by blocking directly this 5-HT3 receptor. So this already I have explained in my previous video, antiemetic drug. If you haven't watched it, I will be giving a link in the description box so you can see now. Now coming to the other things, what are the other hormones which can participate in the gut motility? So one is motiline. Motiline, it is a peptide hormone from the upper GIT. So what it does, from the upper GIT, it is going to come. It acts on the motiline receptor. By acting on motiline receptor, it is going to cause a stimulation of the motiline receptor, and with the stimulation of the motiline receptor, what it is going to cause? It is going to induce gut contraction, it is going to increase the lower esophageal sphincter tone, it is going to enhance the intestinal movement, or you can say the intestinal transit, but without affecting colonic movement. Now, if there is any drug which can stimulate this receptor, motiline receptor, they will be doing all these action. One more, they are going to enhance the gastric emptying also. So this is number 1, number 2, number 3 and number 4. So there is one group of drug that is there which is going to stimulate this motiline receptor, that is Macrolides group of drug, that comes erythromycin, roxithromycin, and erythromycin does that, then clarithromycin that does, and azithromycin. These three macrolides, they stimulate this motilin receptor and causes all these action. So they also increase the gut motility, and for short-term relief of diabetic gastroparesis, it can be used, this macrolides. Now the another hormone which also comes from the GIT, and that is cholecystokinin. It is released in relation to the food. So what it does, it causes the gastric slowing. It decreases the gastric emptying. So what we can do, we can give cholecystokinin receptor antagonist. Like here we are giving the agonistic drug like macrolide. What are they? They are motilin agonist. And this side we can give CCK1 receptor antagonist, that is loxiglutamide. This is the one which can be used to increase the gut motility. So this was all about the physiology of the gut motility. Now just look at once again what are the various neurotransmitters and hormones which are involved in the gut motility. So if I start from here, so number one is D2 receptor. So it is inhibitory. So it is going to decrease the release of ACH. So what we can give, if we give D2 receptor antagonist, so D2 receptor antagonists, they are going to cancel this inhibitory effect. So they are going to cause the release of ACH. So this is number one. Number two is now acetylcholine. If I give directly the cholinomimetic drug like bethanchol, or if I give anticholinesterases, which is again going to increase their indirect acting cholinomimetic drug, they can increase the level of acetylcholine. So can we use that to increase the gut motility? So they cause the contraction of the GIT, but that contraction is a tonic contraction. So we do not use it as a prokinetic agent. Now, and what are the other receptors, neurotransmitter or receptors which are involved? Serotonin. So serotonin is the first one is a dopamine, that is a neurotransmitter, right? So one is a dopamine, second one is a serotonin. Serotonin, it is going to act through two type of receptor. One is 5-HT4. So with the 5-HT4, which exert the excitatory, causes the release of acetylcholine. So 5-HT4, we are going to use 5-HT4 agonistic drug. Now next one is a 5-HT3. Now 5-HT3, it is going to exert the inhibitory influence by causing the release of nitric oxide. So we can give, to increase the gut motility, we can give 5-HT3 antagonist. And these were the neurotransmitter. Main is dopamine, then we have a serotonin. Acetylcholine, I have already told, that is a cholinomimetic drug. That is a big no-no. Now, what are the hormones which are involved in the gut motility? So, the two hormones which are involved in the gut motility are, one is motilin and another one is a cholecystokinin. So, this already I have explained. Motilin receptor, motilin acts through the motilin receptor and it is going to produce various action 1, 2, 3, 4 already just now I have told, and cholecystokinin, it is going to decrease the it is going to slow the gastric emptying. So we can give the motilin agonist like macrolide and cholecystokinin antagonists, they are used as a prokinetic drug. So now how we classify the prokinetic drug? One is D2 receptor antagonist, then we should have a 5-HT4 agonist, 5-HT3 antagonist as such on receptor and all, they are not used, but metoclopramide, it has got 5-HT3 antagonistic action also. Then motility receptor agonist and cholecystokinin antagonist. Now just see the classification of the prokinetic drug. I have classified in the same way. D2 receptor antagonist, then 5-HT4 agonist, motility receptor agonist and cholecystokinin receptor agonist. So, cholecystokinin agonist, this is loxiglutamide. Already I have told how this is going to act. Under this comes various macrolides like erythromycin, azithromycin and clarithromycin. This also I have told you. Now coming to the first one, D2 receptor antagonist. In that comes metoclopramide, domperidone, levosulpride, etopride and citalopram. So I will be covering in today's video these three drugs. Now coming to the first one, that is metoclopramide. Metoclopramide, it is introduced in early 1970 as a gastric urine agent. So this is going to show a dual effect by showing its action both centrally and peripherally. So now let's see the first, the central action. So with the central action, just see the next picture. So here you can see this vomiting center which is present in the medulla oblongata, and close to the vomiting center there is another center, that is CTZ, chemoreceptor trigger zone. And next to the vomiting center. Now this chemoreceptor trigger zone, it is not protected by the blood-brain barrier. So it gets stimulated by various toxins, chemotherapeutic agent with the drugs like morphine, like digoxin and poisons. So once this chemoreceptor trigger zone, it gets stimulated, it is going to cause a stimulation of this. Also, from the CTZ, it is going to cause the stimulation of the vomiting center. Now, on the CTZ, you can see the various type of receptor, especially the D2 receptor, they are also there, and 5-HT3 receptor, they are also there. Now, metoclopramide, though I have classified it under D2 receptor antagonist, but it acts on other receptor also, like it is a 5-HT3 antagonist on the central nervous system. So on the CTZ center, it is going to block this D2 receptor and 5-HT3 receptor. By blocking these two receptors, it is going to block this emetogenic impulses, this travel of emetogenic impulses from the chemoreceptor trigger zone to the vomiting center. So by virtue of blocking these two receptor, D2 and 5-HT3 receptor, this drug, it is going to exhibit anti-emetic action. So apart from the prokinetic, so it is showing the two type of action, dual action by acting at dual effect by showing the dual action. So what are the dual effect? One is anti-emetic and another one is a prokinetic. So anti-emetic action, that is by acting on the CTZ center. Now coming to the second one, on the peripheral action, the second action, which is its prokinetic action. So this drug, it is D2 receptor antagonist. So already I have explained, this is a D2. It has got the inhibitory influence. So what is inhibitory influence? So it is going to inhibit the release of this ACH. Just see the next slide. So D2 action, it is going to inhibit the release of ACH. It causes the gastric dilatation, causes the relaxation of lower esophageal sphincter and delays the gastric emptying. This is a normal how the D2 it is going to exert the action. Now you have given the metoclopramide, which is a D2 antagonist. Now what does it do? Now this metoclopramide it is going to increase the release, just all the action, the opposite of this it is going to do. So it is going to increase the release of ACH, causes the gastric contraction, increases the tone of lower esophageal sphincter and speeds up the gastric emptying. So this is a one part of the peripheral action. Where else this metoclopramide it is going to act? So this is D2 antagonistic action. Second one is it also shows 5-HT4 agonistic action. Now 5-HT4 agonistic action, what it is going to do? It is going to stimulate this excitatory neurons and causing the release of ACH, and again it is going to cause the contraction of the GIT. Then it causes the 5-HT3 antagonistic action. This is a weak, it's a mild action. So by that what it is going to cause? It is going to cause a relaxation, but it is a mild action. So ultimately this is going to facilitate this 5-HT4 agonistic action by having this weak action. So this is about the mechanism of action of metoclopramide. I will sum up here. So metoclopramide it exhibits dual effect by showing its action both centrally and peripherally. So centrally on the CTZ, it antagonizes dopaminergic receptor and serotonergic receptor. So by virtue of its D2 receptor and 5-HT receptor blocking effect, it is going to exhibit antiemetic effect. So this is the central action, right? Now coming to the peripheral action. So peripherally, it has got both antagonistic as well as agonistic action. Now antagonistic action where mainly it is D2 receptor and very weak antagonistic action on the 5-HT3 receptor. Whereas agonistic action that is on the 5-HT4 receptor. It is 5-HT4 agonist and D2 receptor antagonistic action with a weak 5-HT3 receptor antagonistic action, that too at very high dose. So by virtue of its 5-HT4 agonistic and D2 receptor antagonistic action, it exhibits the prokinetic effect. Now coming to the pharmacokinetic of metoclopramide. So metoclopramide is well absorbed if given by oral route, can be given by IM route, IV route. So onset of action it varies. If we give it by IV route, it is going to act within 2 minutes. IM route it is going to act within 10 minutes. And if you are going to give it by oral route, it is going to take half an hour to 1 hour, means 30 minutes it is going to take. Half-life of this group of drug is 3 to 6 hours with the duration of action is 4 to 6 hours. So it is conjugated in the liver. The important point over here is it crosses placenta, enters well in the brain, and it gets secreted in the breast milk. And this is very, very important. It enters the brain. Coming to the therapeutic uses of this group of drug. So this drug, it exerts two type of action. Number one is antiemetic if it is acting centrally, and another one is prokinetic action, that is a peripheral action. So it is used both as an antiemetic as well as a prokinetic. So antiemetic effect where we use it for the post-operative nausea and vomiting. Then drug-induced nausea and vomiting. Now which drug It is apomorphine, right? So many times we have to use the drug to induce the vomiting. Most commonly we use strong salt water solution, or we can use a mustard powder, but sometimes we have to give the apomorphine if the person has consumed something poisonous. Now how this apomorphine it induces the vomiting? This is D2 receptor agonist. So it is going to act on the CTZ, where it is going to stimulate this D2 receptor, and that chemoreceptor trigger zone, it is further going to send the emetogenic impulses to the vomiting center, and vomiting reflex that is initiated and person vomits. Now this group of drug being a D2 receptor antagonist, the metoclopramide, it is a D2 receptor antagonist. So it is going to antagonize the effect of drug induced nausea and vomiting, antagonize the effect of which is produced by apomorphine. Then disease associated nausea and vomiting, especially the migraine. Then chemotherapy induced nausea and vomiting, but nowadays we prefer 5-HT3 antagonist for the early vomiting, whereas for the delayed vomiting we prefer the neurokinin receptor antagonist. Then for the morning sickness, we didn't find any teratogenic potential with this group of the drug, so where the other measure they fail, then we can give this group of the drug for the hyperemesis gravidarum. And where it is not used, in which type of vomiting it is not used, for the morning sickness, it is for the motion sickness. Here it is not at all used. This is a not at all effective. And to enhance the effect of metoclopramide, we can give antihistaminics, we can give even steroid also. Now coming to the prokinetic or a gastrokinetic action of this group of the drug, where you want to enhance this action or a gastrokinetic action. Prokinetic में one is gastrokinetic. So you want to enhance the gastric emptying. If you have to give the emergency general anesthesia, you want to do the surgery and the person has consumed something it's less than before 4 hours, अगर उसको 4 घंटे से भी कम हुआ है खाना खाए हुए, then we have to give this drug. Or you want to give a duodenal intubation, then also we can give this drug. And if there is any gastric stresses because of the post-vagotomy, or if there is any person is any diabetic gastroparesis, there also we can give this metoclopramide, can be used as a gastrokinetic drug. Then where else we can use this one? This one can be used in the indigestion or dyspepsia. Then we say even the functional hiccups, and another is GERD, that is gastroesophageal reflux disease. What is this gastroesophageal reflux disease? So here what happens, there is a reflux of what? Reflux of the gastric content. Instead of moving forward, it is moving towards the esophagus. Then what will happen? Person will be having a heartburn. It is like this. So instead of moving forward, the food particle, it is moving towards this side, the upward here, right? No doubt this lower esophageal sphincter, this act as an important barrier. If this tone is high, then food will not regurgitate. But here the main aggressive factor is the acidity content of the stomach. That is the main culprit. Acidic content of the stomach, which is going to produce most of the symptom, and it can also cause the esophageal erosions. So here the main drug which should be used for the GERD, they are proton pump inhibitor like omeprazole, lansoprazole or rabeprazole, that kind of drug, or H2 blocker like famotidine, ranitidine, that kind of the drug can be given to the person, right? And this group of the drug, they can be co-prescribed with this PPI and H2 receptor blocker. Now coming to the adverse effect of this group of drug. So main adverse effect, they are quite well tolerated. Minimal side effect they are seen with this group of the drug, like headache, dizziness, loose stool, because it's a prokinetic drug, and usually it is going to act by blocking the D2 receptor. It enters the brain. So what can happen? In the brain, we know there is a balance between the dopamine and ACH. Now if this is decreased, then what will happen? This will increase. So extrapyramidal side effect can be seen, but the dose which we give as an antiemetic, that is not that much. It is not going to produce much extrapyramidal side effect except the dystonia in children. This is the side effect. And moreover, because it is secreted in the milk, so in the newborn baby, in the suckling infant, it can cause loose motion, dystonia, and myoclonus. These are the things can be seen in a suckling infants. Now another adverse effect related with this is because it is a D2 receptor antagonist. Now what is dopamine? Dopamine, chemically, it is a PIH. What PIH stands for? PIH stands for prolactin inhibitory hormone. That means dopamine, it is going to inhibit the secretion of prolactin. But if we give the antagonist, then antagonist will do what? Antagonist, it is going to cause the, it is going to increase this prolactin secretion. So what side effect can happen because of this? Hyperprolactinemia and galactorrhea can be seen. So these are important adverse effects with the, and few other, because they are the D2 receptor antagonists, can enter the brain. So it can also cause the Parkinsonism. Another thing is, if the person is already taking, suppose, levodopa for the treatment of Parkinsonism, this is going to abolish, this is going to cancel, ये इसके effect को cross कर देगा. This drug will not act because metoclopramide, it enters the brain, it is going to cancel the effect of this levodopa. That's all about the metoclopramide. Now the next drug in this, that is a domperidone. Domperidone and levosulpride, both their mechanism of action is almost same. So domperidone, in comparison to metoclopramide, it is less efficacious and dual action. Both of these drugs, they act as a dual, just like metoclopramide, with a little bit difference, that is there. Just see the what are the differences of domperidone in levosulpride they exert over the metoclopramide. like central action. So Domperidone and Levosulpride, both they are D2 receptor antagonist. So they are going to block the D2 receptor where they are going to block the D2 receptor here, here and even in the vomiting center. So by blocking this D2 receptor, they are going to exert the antiemetic effect. Now another one is in the periphery. Here also the important is they are going to block this D2 receptor here. No action over here. No action on 5-HT4. This is the difference between domperidone and metoclopramide. So they are their prokinetic action, that is mainly by blocking this D2 receptor, not by blocking, no agonistic action on the 5-HT4. So there is no. So this is the main action of this domperidone. What are the other differentiating feature with this? So it undergo high first pass metabolism. So bioavailability, it is very less with the domperidone, that is 15%. If any drug, if it undergoes high first pass metabolism, that means the drug before entering into the systemic circulation, it get metabolized in the liver. Half-life is 7.5 hours. It's poor entry into the CNS. This is one thing which is advantage, like it is not going to abolish the effect of levodopa. It does not cause the Parkinsonism. Where we can use is post-operative nausea and vomiting, again apomorphine-induced nausea and vomiting, and disease-induced nausea and vomiting like migraine. What are the important side effects with this group of the drug? That is again dry mouth is there, loose stool is there, headache, rashes. Extrapyramidal side effect, they are rare because it cannot cross the blood-brain, it cannot cross the placenta. Its entry into the brain is very poor. But hyperprolactinemia and galacturia can occur on IV injection. Cardiac arrhythmia can happen. Next one is the levosulpride. This also dual action. It also exerts a dual action. That is, but mainly it is a D2 or purely D2 receptor antagonist. This action, it is not seen by these two drugs. So they act centrally also by blocking the D2 receptor on CTZ. They are going to exert the antiemetic action, and by blocking the peripheral action on the GIT, they are going to exert the prokinetic action. So now next D2 receptor antagonists, they are etopride and cinetepride. Both of them, they are benzamide derivative. They are G2 receptor antagonists, but chemically they resemble with this 5-HT4 agonist. Another similarity between these two and with the 5-HT4 agonist is they are purely prokinetic drug. They do not exert dual action, just like these three. So they show antiemetic as well as prokinetic action. So whereas this group of drug, they show only prokinetic drug. So I will be taking this one in my next video. If you like the content of my video, please do subscribe and put up your valuable suggestion in the comment section. So see you in my next video.